The influence of mechanical versus kinematic alignment on knee design performance during walking gait. We utilize KneeSim, a computational kinematic knee simulation software, to evaluate the long-term outcomes of Stryker Triathlon CR components during the activity of walking gait. KneeSim results in measurements of component motions and patella tracking that are associated with patient satisfaction, and contact forces and articular wear paths that are associated with implant longevity. 2 surgical procedures were followed, the classic mechanical alignment and the more recently performed kinematic alignment. Mechanical alignment on the left places the components perpendicular to the vertical mechanical axis, while kinematic alignment on the right places the components parallel to the transverse flexion extension axis, which follows the inclination of the natural joint line in the AP view. These 2 approaches result in different bone resections, placing the TKA components in 2 different orientations, mechanically aligned in blue, kinematically aligned in orange. 2 different KneeSim models were created, one for each case. Different reference axes are used in mechanical versus kinematic alignment. A vertical midplane axis perpendicular to the floor is moved to coincide with the geometric center of the ankle joint. The mechanical axis is typically 3 degrees from the vertical axis. The mechanical axis is difficult to directly visualize in the surgical theater. However, there are many methods of indirectly determining its location. One of these, the transepicondylar axis, determines the placement of saw guides that create bone resection planes that are perpendicular to the mechanical axis. Kinematic alignment seeks to restore the joint line to the individual patient's pre-diseased state, referencing the flexion extension axis. This imaginary line passes through the geometric centers of each posterior femoral condyle. Equal resection, allowing for cartilage wear and saw kerf of the distal femur and posterior condyles, ensures that the resection surfaces are parallel to the flexion extension axis. When the thickness of the implanted femoral component matches the resected bone fragments, the patient's estimated healthy cartilaginous surface anatomy would be restored. The proximal tibial slope is resected to restore the individual patient's original varus and posterior slope. The axial rotation of the tibial component aims to closely match the axial rotation of the femoral component. The kinematic alignment flexion extension reference axis and bone resection planes in orange may be compared to those of the classic mechanic alignment surgical procedure in blue. AP views and axial views are provided for clarity. On average, the kinematically aligned femoral component is 6 degrees more flexed, 3 degrees more valgus, and 4 degrees more internally rotated than the mechanically aligned femoral component. There were minimal differences between the mechanical and kinematic aligned results of both femoral and patella component motions, contact articulations, and forces. Average absolute differences between the stance phase of walking gait were less than 2 millimeters, 2 degrees, and 200 newtons for all results recorded. The motion of the kinematic aligned femoral component in orange can be observed during walking gait. The orange jack is rigidly attached to it, allowing a simplified representation of its motion for easier comparison to the mechanically aligned femoral component jack in blue. The progression of tibial femoral contact areas in both the medial and lateral compartments can also be compared. Kinematic alignment in orange, mechanical alignment in blue. No functional difference was found between mechanical and kinematic alignment surgical procedures during the walking gait cycle with Triathlon CR TKA components. Other product designs that are asymmetrical, single radius, or offer greater articular conformity than the Triathlon CR design may yield different results. Thank you for your attention. And now, your moment of Zen.